This is a very exciting topic, hot off the press. We have survey results for 2018 that we're going to cover. So we're going to talk a little bit about what's going on in Washington today. We're going to talk a little bit about the strategies, the survey results and the strategies and the trends that we're trying to solve for. And then we're going to jump right into what the survey says on things to expect in the future. So I'm not going to, as Kelly said, I'm not really going to have, I'm going to use all 30 minutes of our session today trying to cover the survey results and what they mean. But certainly I always am available to anybody with questions afterwards, so feel free to either call me or email me and I can answer any questions that you might have that we won't get to. But what's happening in Washington, really, I mean, since healthcare reform fell flat in the Senate, there really hasn't been a lot of activity, although yesterday, while he was meeting with Henry Kissinger, he did announce to the press that the Trump administration was going to be issuing an executive order this week to make some changes to the healthcare system in the U.S. Specifically, he left it very vague, but Paul Rand tweeted this morning that they were working on opening state lines so that people could get coverage in other states, which they seemingly think will mean less expensive coverage and more options. I'm not sure that that's going to actually be a reality. And it's a lot more complicated than they think it is, since we have fully insured plans that are state regulated and they have state mandates. So I'm not sure how all of the regulatory issues are going to work. But we will keep you posted. If you go out to my webpage, I do pretty much weekly updates in the news category when any very hot, late breaking news hits. I do editorialize a little bit under the MB's 2 cents section, that tab, so feel free to run out there to the webpage and get some of the latest breaking news. But this morning, the bulk of our time, I've broken this into 2 parts. I've broken it into the medical survey results and what's going on with the medical plans, and I specifically separated the pharmacy piece to cover that in a couple of slides all by itself at the end. And then at the end of this presentation, I have definitions, because we are going to cover some strategies that might not be familiar to everybody, but definitely the survey that we're covering today was done by the National Business Group on Health, and it surveyed predominantly the Fortune 100 companies and what they're doing for 1/1/18. So why this is exciting to me is because when you look at benchmarking data, you're looking at old data, right? So if you think about it, if you're looking at benchmarking data in 2017, it was the things that were done by employers in 2015 and 16 with trends on what that means in 2017. So every benchmarking tool and every survey result, like the Mercer survey that we use as our sister company, those data sets are all pretty stale by the time you're looking at them. This survey is exciting to me because it was done over the summer in 2017, asking companies, large companies, what specifically are you putting in place for 1/1/18? So very exciting that we have some new things to look at. But no surprise for most of us, the 2 major concerns that employers cited were skyrocketing specialty costs on the pharmacy side and the high claimants and the chronic conditions. And I'll tell you in a minute how these 2 really play into how employers are changing their thinking about their strategies. So certainly high claimants, startling information on what's going on in the marketplace. We used to have high claimants that were 50,000, maybe 100,000. Those were our high claimants in the past. And specifically what we're seeing is the high claimants now are significantly high. So they're in the $1 million range. And if you look at just those statistics, you can see Between the specialty drug and some of the new technology and new medical breakthroughs, the high claimants are very, very expensive. And it's come to the point where we used to say, 80% of your dollars are spent by 20% of your people. And now we're saying 90% of your dollars are spent by 5% of your people. So it really has dramatically changed in what a high claimant means. So the survey says we're looking at about a 5% increase across the board for 2018. That is before plan design changes, but that is pretty close to the national trend. So the Mercer survey and some of the other surveys show between 4 and 8% trend increase prior to plan design changes. And what that means for us is in 2017 to 2018, the cost per capita, this is not an employee cost, it's an employee contract cost. So the total cost for an employer per employee average contract size, I think, is still 1.2. So if you look at your total cost, that's a pretty significant increase in 1 year. Employer contributions held steady this year for 2018, so employers are still contributing 70% of the cost of the plan, with the employee contributing about 30%. The biggest difference, and they couldn't statistically break it down, but the out-of-pocket costs are significantly higher than they were in past years. And of course, that's attributable to the consumer-directed health plans or the high deductible plans. So there's a higher out-of-pocket cost for the employee and their family at the point of service. And I think, of course, the thing that we keep pointing back to is ACA is still the law of the land, and that excise tax that is scheduled for 2020, which is only a couple of years away, is still at the same threshold amount, and we are currently on an average over that threshold amount. So, of course, if you're over $10,200 in cost for an employee or $27,500 for a family, you are going to be subjected to that excise tax of 40% in the year 2020 if nothing changes. So consumer-directed health plans definitely have been the prevailing strategy for the last couple of years, and they have absolutely worked, right? So consumerism has definitely been a lever that all employers have pulled pretty much, and you'll see the statistics on the next slide. And they have been effective. So when you have a high deductible plan and you have a health savings account, and when you go to the pharmacy and you have a $300 prescription, it has prompted employees or members to ask the question, is there a generic alternative or a less expensive solution? That's even worked with things like MRI, where people have recognized that the hospital setting might be a little bit more expensive than a freestanding facility. So people have become better consumers with that. But I think what is still very concerning and what we've watched evolve in managing employer paid health care benefits is the chronic conditions. 50% of Americans have some type of chronic condition that they're managing to. The high claimants are an extraordinary amount of cost, and of course the specialty drugs. So large employers, the Fortune 100, have recognized we need some game-changing shifts in strategy to control these things, because the consumer-directed health planning, worrying about a $300 prescription is good, and we should be worried about that, but that's not what's going to save and build our strategy for the future. So just some statistics around the consumer-directed health plan. And again, all of this information is available to you on my webpage, mbgrayhealthcare.com, under the Healthcare Survey, Health Survey Data tab. So everything that I'm going to cover today is underneath that tab on my webpage and available to you. It's not in slide format, but it's in bullet point format, and I've summarized it out there for you. But just for discussion purposes today, obviously the consumer-directed health plans has been a strategy for the last 3 to 5 years. Very successful. 39% of employers are only offering a CDH plan, a CDHP plan for 2018. And they now have surpassed PPOs in average enrollment, so they're the largest populated, heaviest enrollment category. The average contribution to a healthcare savings account for 2018 is $770 annually that the employer is putting into the employee account. And you can take a look at, I guess, the biggest thing is that the deductibles are $15,000 and $3,250 for a family. And of course, 97% of all large employers will be offering a consumer-directed health plan by the year 2020. So they're definitely here to stay. So I think what we see is employers are kind of saying, what is the next opportunity for us? We have a large amount of large claimants that are millions of dollars. We have chronic illnesses that we need to address and try to get people to pay attention to. And what is the next big step in building a strategy? So the large employers have identified that they are taking steps to increase telemedicine opportunities for the employees. On-site clinics are huge, and of course they only work if you have large populations in a single location. But those are becoming more and more prevalent for larger employers or employers with sites that are highly populated by employees. Of course, centers of excellence, they have been around since the 80s, but they have really taken off, and we're going to talk a little bit more about that strategy in a couple of slides. And of course, the transparency tools and the navigation tools. I literally could spend an entire hour just talking about the breakthroughs and the new opportunities that employers have with transparency tools and navigation tools. You know, there's all kinds of cutting-edge technology. For those of you who have participated in my webinars in the past, you know, I did a whole session on IBM Watson and the artificial intelligence breakthrough that they've had with trying to get people in certain types of very, very expensive high-tech conditions information on the best course of treatment. So that is, I see, a very huge emerging strategy that's going to really be front and center, in my opinion, in the next couple of years as something that's a need to have, not a nice to have, if you want to control costs and you're a self-funded employer. Spousal surcharge, I just put this in because everybody asks me about this. You know, what do we do about spouses? If you look at your utilization and you find your high claimants are spouses instead of your employees, a lot of companies have taken the stance that they're going to charge employees for having their spouse on the plan. The average charge for an employee to have their spouse on the plan is about $100 a month. And 6% of large employers this year, in 2018, will be excluding coverage for spouses if they have coverage elsewhere. So just some good information to have. And I'm going to talk a little bit now. This is the exciting part, at least for me. This is where we're really seeing the shift in the way that we think of things. And before, you know, in the past years, we've all been focused on how do we change our plan design, what elements do we put into the plan design, or what co-pays and deductibles and things can we tweak to get people to change their behaviors and be more cognizant of how they're using healthcare and the dollars spent, right? And now large employers, and we're talking employers that have, you know, 50,000 employees, the Fortune 100, they're looking at the supply chain on the delivery side and how do we work with a more advanced strategy and a more advanced way of thinking. So we're going to cover in the next 3 slides 3 strategies that the large employers are using. I have to say that middle market, my market, these aren't prevalent strategies, but I really want to cover them because I think they're going to be prevailing strategies 3 to 5 years from now for middle market. So healthcare is local, right? Everybody knows that. If you're in a small city, you might have 2 hospitals that compete in the marketplace. In Philadelphia, we have 92, which is an extraordinary amount of options. But an ACO, so the definition really of an accountable care organization is a provider, usually a hospital system or a group of hospitals that have come together to create an accountable care organization, and they participate in the risk. So they're basically taking a portion of your population, and they're responsible or at risk for delivering care for that population. And it's really, the way that I look at it and think about it in my head is really, it's like a mini HMO, right? So back in the 80s and early 90s, we had health maintenance organizations where you had a gatekeeper, you had a primary care physician that was supposed to be quarterbacking your care throughout the process. This is it's a similar strategy, but it's a healthcare provider being the quarterback of your population. So they do the population health management. The healthcare providers are being pushed to be accountable for the quality and the cost of care for a defined population. So hopefully, if anybody has any questions on where they're available, there's over 960 ACOs available in the United States in various areas. Some a little bit more further down the path of care management than others. But what they focus on is like readmission rates. They're trying to keep readmission rates down. They're very focused on chronic condition management, ER utilization, emergency room utilization. And the next generation of focus for most of the ACOs is pharmaceutical optimization. So when they look at their population of diabetics, they're looking at not only are they monitoring and measuring their glucose, but they're adherent with their medications, and diabetics have comorbidities with lots of other things going on. They're making sure that the whole host of medications that they take are in sync with one another and they're adherent. So just kind of a new technical term, but very, very interesting new way. I think the other reason I think, we have one of the biggest business verticals that my company does businesses in is hospitals. We have over 97 clients with over 900 locations. We have Children's Hospital Association that we do business with, which is close to 100 children's hospitals across the country. But they're struggling right now. Hospitals and health systems are struggling. They've been hit with reduced reimbursement rates and really being squeezed in so many directions, including on the pharmacy side. So it is interesting that they're trying to figure out where they fit into the healthcare system in the future. And I think they're looking at these ACOs and taking on risk and reward and better managing patient populations as kind of their next challenge as well. 21% of large employers are going to be actively promoting this strategy for 2018 in geographical areas that they have populations in where they're available. And again, I have a slide with a little example and a definition in the back. High-performance networks and centers of excellence, this is not new, okay? I was doing this in the late 80s at U.S. Healthcare. These are definitely not new ideas, but I think where these have come forefront and front and center with insurance companies, so you're, as a self-insured employer or a fully insured employer, these may be available through your carriers. But they've identified facilities and treatment centers and selected hospitals with higher positive outcomes for certain types of categories of illness treatments. And again, this is the hospital systems trying to figure out what's our niche, what do we do the best, and what are we going to become the center of excellence for and garner more business. Cancer treatment is a particular area that is very, very popular in this category. So you have Sloan Kettering Cancer Center, MD Anderson, where they focus on certain types of cancer treatment and research because they want to be the best in the world at that and become designated as a high-performance network or a center of excellence for treatment. As an employer, you go through the accountable care organizations and this high-performance network and centers of excellence. you go through your carriers to set these up. So these are with your partner carriers helping you set these up. So the last kind of big strategy that I think the survey shows is being very predominant. This one is exciting to us. So in the middle market, anything below 10,000 employees, you should be thinking about these. And if you're not implementing these, you definitely need to start in 2018 taking a look at this opportunity. We did a session in Austin where we did an hour program on value-based plan designs, and I am actually going to do a case study because there was so much interest after that session. People really wanted more information on how do you develop one, how do you implement it, how do you figure out which ones to implement. We are actually going to do our next power lunch on November 8th. Where we're going to take 20 minutes and kind of go through a case study. So a value-based plan design, again, 40% of large employers have some type of incentive for their members. But the best example of a value-based plan design, I always use diabetes. So if you look at your year-end utilization information from last year and you pick out your top driving categories of disease, typically you can design one of these around what's driving your cost or one of those categories where you're running hot. Diabetes is always one of the top 5 when we look at utilization for each client. And if you look at your population of diabetics, you look at, are they adherent with their medications? If they have a 90-day refill, are they getting their refill every 90 days or are they getting it every 145 days? Because then if they're getting it filled at 145 days, you know they're not taking their medicine every day. So you can design a program where you can say to your diabetics, and again, this is through your carrier, so your carrier's doing the data analysis with us, and we determine who falls into that bucket or category. And then the carrier reaches out to them and says, we've put a value-based plan design in place for diabetes. And if you participate in coaching and the 3 other things that we need you to do throughout the year, you can do it 2 ways. You can either say all of your medications and supplies are covered for free. There's no copay. We're making them free to you if you participate. Or a lot of companies now are saying you get an added contribution to your healthcare savings account. So either way, you basically put some type of incentive in there around behavior. The other thing that is very popular this year, and I think, again, it crosses down into our space as well as the jumbo employers, but is additional services to members. So employers are looking at the second opinion or concierge service for employees that either have complex healthcare situations or high cost of care, people on specialty drugs, things like that. And those can include, coaching, high-touch advocacy services. It's very interesting because this space has really evolved in the last 3 years. I do conferences across the country all year. And I cannot believe the amount of new companies we see at these conferences that are supplying and offering these services. And it's kind of a wraparound to your carrier services, so it's an add-on. But some of them really put a lot of performance guarantees in place. They put their fees at risk and an ROI. Very interesting new opportunities. One of the ones that I like in this space is Best Doctors, who does use IBM Watson artificial intelligence technology in the background. I think I might not be specifically accurate on this, but I think they said that when they are involved in a second opinion on a high cost case, 62% of the time the course of treatment changes, which is both scary and surprising. I think good and thoughtful to make sure that we're approaching the care in the best way possible. So kind of in summary, because I have about 6 minutes left, I want to cover the pharmacy piece. But in the summary on the medical stuff, clearly the focus has shifted from basic plan design changes and cost shifting to the employee. into much more thoughtful strategies on the delivery side of the system. So we're really, I think, seeing employers for the first time pushing for better outcomes and higher quality. Some of the things that are helping the large employers is what CMS and the government's doing on the Medicare side, because they're also pushing this lever as well on the millions of people that they cover under Medicare and Medicaid. So we're going to jump real quickly into just a couple slides on the pharmacy, because we certainly covered a little bit of that in the front part on the medical side. But the survey was very specific that this is a driving cost and it's a driving issue, and it plays big into the high claimants, right? So if you looked at that first slide again and you saw those, the chunk of people spending almost $1 million in the high claimant bucket, a lot of that is due to these specialty drugs. And I'll tell you, I am not a doomer and gloomer. I'm usually half glass full kind of girl. But when you look at those specialty drugs and what's going on with them, it is startling because historically the specialty drugs were used to treat just a small handful of diseases that were, very specific and dangerous illnesses, life-threatening illnesses. And now we significantly see that change. And for the first time in the history, we're seeing 50% of the drugs in R&D and development are specialty drugs. And I think the other thing that wasn't really pointed out in the survey, but anecdotally, the drug companies are focusing on chronic diseases like MS, and so things that Parkinson's, things that don't change your longevity, but you are literally on these specialty drugs for decades. So that's where they're spending most of their time, and it's obvious that's where they're making all their money. So, we've expanded them to very common conditions now. There's a specialty drug for cholesterol medication, and millions of Americans are on cholesterol lowering medications. And if you look at the generic form of that, it's $10 a month. Lipitor, the name brand, is about $100 a month. And the PCSK9 specialty drug for lipid control is over $1,000 a month. So just think if you're on that for 10, 15 years, the total cost of that is astronomical. And of course, if you look back in time, in 1990, there were 10 specialty drugs on the market, and now there's over 300, and there's plenty in the pipeline to be concerned about. So we've identified that as a problem. 60% of employers are trying to solve for that by carving out the pharmacy and going directly to a pharmacy benefit manager. I had the question this week from a prospective client: can I carve my pharmacy out if I'm fully insured? And the answer is no. Unfortunately, you cannot. And the reason you can't is because if you carved your pharmacy out and pulled it onto a self-insured basis, you can't get stop loss for pharmacy only. And some of these drugs are millions of dollars, so the exposure and the liability is far outweighs any benefit that you would see. So carving out is really a self-insured employer opportunity only. And then, of course, in that subset of folks that carve out the pharmacy, you have 18 to 20% of employers that have joined a pharmaceutical coalition for better purchasing and pricing. And really all that is leveraged purchasing, right? So Trion has a pharmaceutical coalition where we've gone out to CVS Caremark, ESI Medco, which is the largest, and OptumRx, which is owned by United Healthcare. And we've developed preferential pricing and preferential performance guarantees and terms because we're going to them with 800 clients with over million bodies in the bucket. So we're actually being able to leverage and get better terms and pricing for our clients to take advantage of. And by 2020, 9 out of the top 10 drugs. So when you look at your utilization at the beginning of the year, you go through open enrollment in the first quarter, we're asking for year-end utilization to see what's driving our costs from the prior year. It's really interesting because right now we're looking at it, and about 50% of the drugs are specialty drugs, and that is going to change. 9 out of 10 drugs are going to be specialty drugs, which is not good news for us. And then, of course, price increasing. You can see the study by the Mayo Clinic is frightening. This is really kind of the last slide that I wanted to touch on, and I know I'm right at the 30-minute mark. I told the ladies at the conference it was going to be hard for me to get through all of this in 30 minutes. It's such good stuff. But two emerging issues. You know, the top therapy classes are very standard classes. And this third bullet point of oncology, this is the concerning one for all of us. So these are emerging issues to watch. And because oncology drugs are injectables that are injected at the physician's office, they're actually being processed through your medical plan. So right now, since this category is one of the top three, 50% of your specialty drugs typically are now running through your medical program. So these are the J codes and the Q codes that I always talk about. I've been talking about them for 10 years, I feel like. These are becoming a big problem. It used to be 10 to 15% going through the medical plan. 50% of your specialty drugs. So if you look at your utilization under your pharmacy and you know what your specialty cost is, on a 1,000 life group, it's usually about $1 million now on the specialty side. If you look at that, there's probably another chunk going through your medical plan that you're not aware of. So again, there's strategies to deploy on this, but this is something that you want to be asking about, you want to be looking at, and certainly, you know, something to be quite cognizant of and trying to figure out what you can move back to the pharmacy, because those are items, if they're going through the medical plan, you're missing all your clinical programs that you put in place on the pharmacy. So they're not going through step therapy. They're not going through the different copays. They're literally getting that through their deductible and coinsurance on the medical side. So they're kind of skirting or circumnavigating our plan clinical edits. So that's not good. Next month, just in summary, again, I'm going to do a value-based plan design case study, and I promise I will stick to my 20 minutes. So grab your lunch. We're going to do a legislative update, a little bit on what a value-based plan design is, more in depth, and a case study to improve diabetes. I did put in the back here a definition of what is an accountable care organization so that you have the definition in writing. I did the same thing on a value-based plan design back here. And of course, I did the Cadillac tax update because this is back. This is something that we have to